Very good evening to everyone. We are here with yet another virtual session, and today's virtual session would be taken by William Clearfield, who is a medical director of Clearfield Family Medicine, and he is also executive director of American Osteopathic Society of Rheumatic Disease. He have completed his studies in 1978 at the College of Osteopathic Medical Medicine and Surgery, and he has completed his internship from the OB and Gynec resident at Metropolitan Hospital, Philadelphia. He served in a family practice residency from 1980 to 82 in the United Health and Hospital Services. He have done he have went for the acupuncture for physician program and served as secretary of the American Academy of Medical Acupuncture and was editor of the General Medical Acupuncture from 94 to 96. In 2002, he have attended a workshop with instruction on testosterone hormone replacement, implants, and neuromodulator for facial rejuvenation. He was the first for a while only practitioner in the Northeast to offer hormone replacement implants and Botox for facial rejuvenation. He have trained medical aesthetics, perfected the Clearfield facelift, utilization a combination of neuromodulators, derma fillers, PDO threads, and platelet-rich plasma. In 2020, he welcomed the first class of the Clearfield training program, offering instructions in bioidentical hormone therapy and medical aesthetics. Represented the Nevada at the American Osteopathic Association House of Delegates in 2018 and 19. And as we have introduced in the beginning, he is the executive director of the American Osteopathic Society of Rheumatic Disease. With this small introduction of Dr. William Clearfield, I welcome you on your growth platform. Thank you so much, sir, to come and share your time with all of us.
Thank you for inviting me. So if we could share our screen, and it's not there. Okay. My slides are not there. Here they are. Okay, let's see now. I apologize. There we go. There we go. I apologize right off the bat. So
no
problem. Okay. Well, I'm very happy to discuss any topic with your students, and thank you for that lovely introduction. We in our clinic, we look at medical issues, and especially chronic medical issues, in slightly different fashion. We sort of are hormone centric. We look at hormones as sort of the base of everything that we do, and if we look at it as the base or frame, you can buy an expensive piece of furniture, but if the frame is not holding up, if you don't have a good roof, the expensive furniture, which is our brain, in this case, it will not fare very well. This is a fairly advanced topic, so I thought I would begin with a brief introduction to peptides. Realize that pretty much every slide that we go through and every topic could be an hour, at least an hour lecture on its own. So I'm going to quickly go through some of the basics of what peptides are, and why they even exist in the first place, and then we'll get into the topic at hand, which is enhancing the brain peptides. So usually in a CME medical lectures, there's a disclosure. I have no financial interests, if that's of a concern. I am the executive director of the American Osteopathic Society of Rheumatic Diseases. We are a accredited subspecialty of the American Osteopathic Association, and we are now a grantor of American Medical Association educational credits also. So peptides are actually groups of amino acids that have been linked together. Two or more amino acids linked by a peptide chain are our basic unit. Peptide chains are usually 50 or more combinations. They enable growth and repair, and they give cells body and shape, and they're usually an energy source. They're structurally similar to proteins, the amino acids. Less than 50 amino acid chains are called oligopeptides. 21 to 50 amino acids are considered polypeptides, and greater than 50 amino acids are called proteins. So just so we get some basic language down. They give sequence, shape, and the type of amino acids involved determine the peptide's function. The first peptide, there's a schematic of it. The amino acids are pieces of a unit. Peptides are less than 50 amino acids linked in a chain, and the proteins are greater than 50 amino acids linked in a chain. There are 7,000 known peptide sequences. 500 of them have been found to have some therapeutic value, and there are now 61 US FDA approved peptides as approved as medications. What we're going to be looking at are peptides that address immune dysregulation, inflammation, and reactive oxidative stress, and we're going to look at some combinations. In therapy, we've used peptides for traumatic brain injury, joint injuries, infectious diseases, including viral infections. We've actually found some of the peptides, the immune peptides are quite potent in warding off the COVID-19 virus, COPD, cystic fibrosis, ulcerative colitis, and sleep, memory, anxiety, depression, cognition, cellular and rejuvenation and restoration, and pain relief. We started working with about 3 or 4 peptides approximately 12 years ago. In the last 3 to 5 years, there's been a huge increase in the number and function of them. There's probably greater than 90 that are readily used by different, some of my colleagues. I'm pretty comfortable, fairly comfortable with about 15 of them, and we get some very good utilization out of those 15. Peptides differ from hormones in the fact that hormones act on a nuclear receptor, and the peptides act on membrane receptors. Hormones activate genes, and peptides activate intracellular signals. Hormones synthesize protein, and they act slowly. Peptides act quickly, and hormones act globally. They usually affect the whole body, and the peptides usually are only either local or regional. So that's sort of the basics of what a peptide is. Where they came from, and I'll call it the word from our sponsor, they came from as a derivative of growth hormone. So why do bother with peptides in the first place? And it comes with the trouble with growth hormone. This was a lecture I gave at the Nevada Homeopathic and Integrative Medical Association in September of 2019. And again, we could spend 3 to 4 hours on growth hormone alone and its derivatives, but I'm going to give you just a brief overview so you understand that we're going to take pieces of growth hormone and turn it into these peptides. So growth hormone is 191 amino acid polymers. They're linked in a specific manner in a specific order. And I liken them to Legos. So if you get a box of Legos or Tinker Toys or some sort of toy box that you can put together, and it becomes over here, there's a car, over here, there's a windmill. Here's the sequence. It's 191 pieces. Growth hormone stimulates growth and cell reproduction. Growth hormone is what it says it does. It increases a child's growth until the growth plates are closed, usually between ages 15 and 18. But adults need a growth hormone in small amounts to maintain homeostasis and really good health. Growth hormone is produced via 2 pathways. On the left-hand side, this is the growth hormone releasing hormone pathway, and this is a stimulation in the hypothalamus, which stimulates the anterior pituitary gland to produce growth hormone, growth hormone then is conjugated into IGF-1, and it's IGF-1 that does the work of growth hormone. And if you do not get a conjugation of growth hormone to IGF-1, we have dysfunctions. And the most famous one that we've come across is really early autism. So in early autism, ages 1 to 3 months, we find that these babies' heads are extremely large. They have elevated growth hormone versus their 1 to 3 month old peers, but the IGF-1, the usable portion, is actually low. In Montefiore Hospital in New York City, in the US, they actually have a clinic where they administer exogenous IGF-1 with good results and diminishing the autistic symptoms. So there's a disconnect between growth hormone and IGF-1. On the right-hand side, there's the second pathway. This is the ghrelin pathway, and this is through the stomach, which generates growth hormone releasing peptide. This stimulates, again, the anterior pituitary gland to produce growth hormone. The peak production is between 10 p.m. and 4 a.m. And when we draw laboratory studies, we need to get them about 4 hours after that to be accurate. You need to do a laboratory study for growth hormone or its derivatives. You need to get it between 8 a.m. and 10 a.m. Those who have, do travel, especially international travel, and experience jet lag and or even night shifts, know that growth hormone is one of the hormones that is greatly disrupted without a normal or diurnal rhythm. This is just a slide that shows different substances that will affect either the positive effects of the growth hormone stimulating hormone and growth hormone releasing peptide, or over here on the left, somatostatin, which is a negative influence. That's what these little lines are, negative influence on growth hormone releasing hormone. And so later on down the road, when we study how hormones interact with each other, this becomes relevant. But I thought your students might be interested in seeing how all of these systems actually interact with each other, and they're not in discrete units. Growth hormone is especially in adults, is necessary for brain function, for the skin and hair to be full and shiny, for sleep quality, for the immune system, particularly T cell production and interleukin-2, for sexual function, bone density, body fat, and cardiac preservation. So growth hormone in the adult is extremely important, and we need a certain amount, not a whole lot, but just but enough to be able to maintain these functions. Rudman in 1991 published this famous paper in the New England Journal of Medicine, which accelerated the interest in growth hormone. He gave patients 0.03 milligrams of synthetic growth hormone per kilogram body weight 3 times a week for 12 weeks, and he found an 8.8% increase in lean body mass, a 14% decrease in adipose tissue mass, 1.6% increase in lumbar bone density. Skin thickness was increased by 7%. And this set off the growth hormone interest. IGF-1, which is insulin growth factor 1. So this is the downstream portion. This is sort of like the free or usable portion of growth hormone, and this is the hormone that affects all of the organs. We need adequate IGF-1 for growth hormone to perform its functions. Growth hormone stimulates thyroid activity by up to 31%. It stimulates testosterone by 25%, and it decreases sex hormone binding globulin by 32%. In traumatic brain injuries, which is one of the areas which we specialize in our clinic, growth hormone is the first and most common deficiency. 20% of patients after an acute traumatic brain injury, and it doesn't have to be a severe traumatic brain injury, mild traumatic brain injury, which is no loss of consciousness and a physical recovery within less than 6 hours, that these patients within 96 hours exhibit 20% of them exhibit significantly decreased growth hormone levels. At 12 months, without intervention, that rate increases to 35 to 40% of traumatic brain injury survivors. And this, again, this is mild traumatic brain injury. There's our references down there. Growth hormone deficiency results in memory loss, concentration, mental clarity. This is what we call executive function. Obsessive compulsive tendencies, dark moods, paranoia, poor concentration, anxiety. On a lighter note, low growth hormone results in patients who are unable to start projects, unable to finish projects, unable to change direction. We're sitting here discussing growth hormone, and in one of my former lives, I was an emergency room doctor. If, say, somebody out my front door got hit by a car, could I turn this off and go and become the emergency room doctor again? Some people can't do that. Also, the ability to be able to do two things at once. And again, some people, the patients with low growth hormone levels have difficulty in performing these tasks. Paranoia, even suicide ideation, poor cognition, poor mental alertness, poor work capacity. An adequate or a growth hormone will stabilize all of these functions. Again, down here, here's your reference for that. Adequate growth hormone in the immediate traumatic brain injury time frame within 48 hours decreases mortality from traumatic brain injuries by 50%. Adequate growth hormone post-MI decreases mortality by up to 380%. In men, about 3-to-1 ratio, and in women, there were actually in this study no fatalities in women who had adequate growth hormone 3 years post-MI. Side effects of growth hormone. And now we are back. And so growth hormone has great qualities, but there are some issues with it. To reiterate, long-term safety, 28-year study found no increase in mortality in children's or adults treated with growth hormone, no increased evidence of strokes. Again, a myth of increased malignancies and new malignancies, that was not found to be so. No increased incidence of leukemia or extracranial tumors, and patients without risk factors, history of radiation, found no increase in intracranial malignancies. There are legal issues, at least in the US, that growth hormone is deemed illegal for off-label use for quote unquote anti-aging. And in the town where I live, Reno, Nevada, there was a famous case with a very famous doctor who was eventually acquitted, but the US government tried to make a case against him for prescribing growth hormone. Legally, it's available or indicated for growth hormone deficiency in children, Prader-Willi syndrome, Turner syndrome, idiopathic short stature, and growth failure. In adults, it is legal for growth hormone deficiency, radiation therapy, and for trauma. Again, to reiterate, bodybuilding, athletic performance, and for anti-aging issues, it is deemed in the US illegal. However, the good outweighs the bad by 15 to 20-fold. And so this is a line from an old song written by Johnny Mercer during World War II in 1944. And you've got to accentuate the positive, eliminate the negative, and then latch on to the affirmative. And so we're born growth hormone mimetics. And this is where the peptides come in. So the peptides are pieces of growth hormone that have been reformulated. And with the reformulation, we get various and sundry properties of those proteins that have, or those amino acids that have been reconstituted together. So this is a big effort. There's a lot of biochemistry involved. Um, like I said before, we were able to use, there were 3 to 5 of them when I first started learning about these about 10 or 12 years ago. And now there's about 85 of them, of the proteins that we use. I use about 15 or 20 that I'm comfortable with. So the positive is a lean body mass, strength, energy, mood, positive outcomes with traumatic brain injury, cardiovascular performance, cancers, outcomes, autism, schizophrenia. The negatives of growth hormone are paresthesias, arthralgias, joint pain, insulin resistance, edema, the so-called addiction. There's a very narrow therapeutic window, and we can easily become accommodated to it. And sometimes if we stop growth hormone, we do not recover quickly or easily. It's almost like an addiction, and of course, there's legal issues. So these are just categories of peptides. So remember, peptides are amino acids that are less than 50 entities linked together. And remember, we talked about growth hormone releasing hormone. That was the growth hormone that is released from the hypothalamus to the pituitary. The original one was semirelin. It's the first 29 amino acids or proteins or amino acids or building blocks of growth hormone. This was FDA approved drug in 1991. It has actually been taken private now, and it has to be compounded or made. CJC 1295 is a synthetic of semirelin. It's also 1 to 29, the first 29 amino acids, and it's actually 0.5. So this has a lysine molecule added to it. And what this does is extends the half-life from about 6 hours to 6 days. The growth hormone releasing peptide, which is the ghrelin pathway, is growth hormone releasing peptides 2 and 6. Those were the original ones. Ipamorelin and hexamorelin are synthetics. Hexamorelin is FDA approved for HIV lipodystrophy. It would definitely work for lipodystrophy if you're not HIV positive, but that's what the official indication is for here in the US. Immune modulating peptides, thymosa alpha-1, which was used quite successfully in previous coronavirus outbreaks in 2005 and in 2011. Thymosa beta-4, which increases Th1 and decreases Th2, BPC 157, and they're all synergistic with a pineal protein called epithalon, which actually has been shown to increase life in at least in lab rats. For rejuvenation and pain, BPC 157, thymosa beta 4, epithalon, DSIP is for sleep, and the growth hormone releasing peptide, this one here, that's again a semirelin. For osteoporosis, we have one called LGD 4033. All of these are separate topics. These are all separate lectures. The brain peptides, the ones we're going to talk about tonight, are with memory, depression, anxiety, traumatic brain injury, brain function. The 3 main ones that we use, one is called cerebrolysin, number 2 is called CMAX, number 3 is Salank, and they are synergistic with some of the others. There's the sleep peptides there. The last one there, AOD, is actually AOD 9064, and that is actually useful, besides sleep, is actually useful as for fat burning or for weight loss. And there's an antimicrobial LL37, which is quite effective against Lyme disease, viruses, fungal infections, and parasites. Obviously, these are not first-line medications, drugs, or interventions, but these are for more difficult cases. So, meet the new nootropics, the brain function. These are smart drugs designed to stimulate and regenerate your brain. And believe it or not, if you look in your pantry, you'll probably find some right there. They enhance memory and learning. They protect neurons under oxidative chemical assault, cerebral ischemia, strokes, drug effects, neurotoxins. They increase neural efficiency, enhance focus and motivation, and they're relatively non-toxic. The most famous of all is caffeine. It's a stimulant and mood elevator. It was actually described in ancient Chinese and Arabic texts as with, especially Arabic texts, with goats are consumed by berries of the coffee plant, and they, quote, gambled about, frisked about all night instead of sleeping. L-theanine is a green tea extract, and it tempers the side effect of caffeine. And so the jitteriness, insomnia, even elevated blood pressures, L-theanine seems to temper. And so we can find a combination of 50 milligrams of caffeine, 100 milligrams of L-theanine, and we get an increase in speed, performance, and cognitive function without the jitteriness of caffeine alone. Other smart drugs include creatine, which improves short-term memory. The doses are right here. Bacopa, which increases focus and attention and decreases anxiety. Paracetam and choline, which is a GABA derivative, GABA being the anxiolytic rather, a neurotransmitter. Rhodiola improves memory and enhances cognitive skills, and Asian ginseng improves memory and memory retention. And so now our neurotropic peptides. Cerebrolysin is anti-inflammatory. It reduces free radicals. It modulates inflammatory cytokines. It has neuroplasticity, neurodegenerative, and neuroprotective functions. It contains growth factors. And there they are: insulin growth factor 1, insulin growth factor 2, glial cell derived neurotrophic factor, and ciliary neurotrophic factor. These counter the adverse effects of fibroblast growth and in scar formation, especially in the brain. We spend a lot of time studying cytokines, and we look at a lot of the substances and medications, supplements that we choose are against the cytokine storms. So cerebrolysin will improve the profile in interleukin beta 1, TNF alpha, NF kappa beta, interleukin 6, which we found is most important in almost all of our disease processes, interferon gamma, interleukin 2, and ACE2. It will increase brain-derived neurotrophic factor, and interleukin 10, which is an anti-inflammatory cytokine. The neuroplasticity and neuroregeneration properties of cerebrolysin render it quite effective in recovery from traumatic brain injuries, strokes, and dementia. And here we are. This study was done in 2001, cerebrolysin 30 milliliters per day, 5 days a week, 147 patients, 4 weeks, starting 4 weeks post cerebrovascular accident. There was a 200% increase in cognitive scores in the MMSE exam. ADL scores were improved by 35% versus control. 85% of patients showed some improvement. It showed a regulation of glycogen synthase kinase 3 beta. It decreased amyloid deposition, microtubule issues, associated protein. It increased synaptic density and restored neuronal cytoarchitecture, and it improved cognitive and behavioral performance. On average, it decreased recovery time from 90 days to 20 to 21 days. In other words, patients that were not treated with cerebrolysin at 20 to 21 days where patients at 90 days untreated were. It improved cognitive function, and mortality was reduced with early cerebrolysin intervention. It tempered oxidative stress, neuroinflammation, modulation, destructive cytokines, chemokines, and it tempered brain cell mitochondrial destruction. Again, 28 days of post-TBI therapy with cerebrolysin showed as much cognitive recovery as those who were not treated at 1 year. So quite a bit of a 12 times the acceleration of cognitive recovery. Here are different dosing structures, situations. You can do a single 50 milliliter dose. We usually treat patients, these are usually sub-Q, and we usually treat patients at 2 to 3 days per week after an initial course of 10 to 20 days. The typical course is 21 days on, 7 days off, and then 2 to 3 days per week after that. I don't typically do IV injections. We usually do IM, and we do up to 5 milliliters. And we can do, if we do IVs, we can add a vitamin. We use a vitamin B mixture with vitamin C and magnesium, and that can be mixed with the IV solution. That has to be in a drip, though, not as an IV push. Contraindications are drug hypersensitivity, epilepsy, and severe renal impairment. Do not mix these with amino acid solutions, and we must be careful with MAO inhibitors. We need to lower the dose. Safety studies, 5 times human therapeutic dose over 26 weeks showed no substance-related intolerability, no teratogenic, embryotoxic, or fetotoxic effects, no antibody formations, no carcinogenesis. Again, different dosing structures. We like this one also, 5 days a week for 4 weeks, 2 to 4 cycles a year, 10 milliliters per day for cognition, 30 milliliters a day for behavioral issues. Cranial cerebral trauma, 10 to 50 milliliters. We can give that as an IV push or IM. And the sooner we treat patients with this, the better recovery we get. Children, we can water that down to 1 to 2 milliliters. This is just, again, a treatment regimen for different cycles. Cmax is an ACTH, a melanocyte stimulating hormone analog. It is neuroprotective, anxiolytic, antidepressive, and an analgesic. It increases brain-derived neurotrophic factor. It increases serotonin and norepinephrine. It acts as an antidepressant and an anti-anxiety agent. It encourages growth and differentiation of new neurons and synapses, and it improves long-term memory retention. The cytokines involved here are interleukin beta-1, interleukin-2, interleukin-6 again, and tumor growth factor beta-1. It will increase brain-derived neurotrophic factor, serotonin, and dopamine. It improves memory, learning, and attention for attention deficit. It augments psychostimulants on central dopamine release, and it modulates brain development. It's indicated for anxiety, depression, memory retention and learning. It increases mental processing and improves mental recall. It is useful in hypoxic states, including transient ischemic effect, cerebrovascular accidents, and acute MIs, heavy metal poisoning, and also for chronic pain. ADHD, migraine headaches. It will help improve intellectual capacity, mental clarity, mood stabilization without getting a high feeling. It improves energy, visual acuity. It expands visual fields, improves color vision, improves olfactory sense, and increases electrical sensitivity of the optic nerve. Doses 30 to 100 micrograms sub-Q once a day, 2 times weekly. And any more than that, you can get an accommodation or desensitization. It depends on the patient's response. And we can alternate this, and we frequently do. We'll do 3 weeks on, 1 week off with Cmax, and then we'll alter it with Selank. That's our next peptide. Here are the references for the information I just gave you. And then Selank, and this is actually my favorite one. It's an anti-anxiety, antidepressant. We use it for opioid addictions, alcohol withdrawal, and dependence. It's an immunostimulatory peptide. It's located in the heavy chain of the IgG, and it modulates interleukin-6, 5-HTP, dopamine, norepinephrine, T helper cell cytokines. It increases brain-derived neurotrophic factor, and it helps it reduces the breakdown of enkephalins. Again, cytokines, it will increase the anti-inflammatory interleukin 4, decrease interleukin beta 1, interleukin 6, TNF alpha, and TGF beta 1. Putting Salank against benzodiazepines. Benzodiazepines act by altering the affinity for the GABA A cell receptor, and Salank does the same. Benzodiazepines potentiate GABA, and Salank potentiates GABA to a greater degree than the benzos. But the problem with benzodiazepines, of course, is they're sedating, they're addictive, and they create cognitive issues, and we don't see this with Salank. Here are the references for that information. Salank upregulates brain-derived neurotrophic factors and serotonin. It's anti-inflammatory. It's adaptogenic. It is useful against environmental stressors. It increases intracellular antioxidants, blood flow to the brain, decreases blood pressure, alleviates anxiety and withdrawal symptoms, exhibits a penchant for some weight loss, and lowers cholesterol versus a control group, increases lymph flow to the gastric lining, and it inhibits mast cell activity, rendering it useful for mast cell activation syndrome and for POTS syndrome, which is rapid heart rate via the autonomic nervous system. And we frequently alternate Salank 1 month on, 1 month off, 3 weeks on, 1 week off for each one of those. We like Salank a lot because it's a nose. We get it as a nose spray, 2 or 3 drops once or twice a day as the dose. Here are the references for all of those. It's actually, it's officially indicated from the Russian Health Ministry for anxiety, depression, chronic fatigue, adrenal fatigue, anti-inflammatory, and has antiviral and anti-inflammatory activity. 2 to 3 drops of a 0.15% intranasal spray 2 to 3 times a day. Make sure it's refrigerated. And we rarely, I've never had any patients complain of fatigue with this. These are some of the areas that I've been studying over the past several years. And what I've just outlined for you are the cytokine abnormalities that develop from these issues. So for autism, interleukin 6, TNF alpha, and interferon gamma are elevated abnormally versus controls. In traumatic brain injury, interleukin 1 beta, interleukin 6, and the calcium chloride channel flow are disrupted. In gadolinium deposition disease, and this is an extremely interesting issue, these are patients that develop brain neurotoxicity and severe pain and burning skin syndromes from IV MRI dye. And it seems to be more and more prevalent than at least I realized. Interleukins 2 and 6, interferon gamma, TNF alpha, TGF beta, and interleukins 8, 18, 23, and 31. And post-finasteride syndrome. So finasteride is a drug that's used for benign prostatic hypertrophy and hair loss. And unfortunately, it will at times affect mental clarity, and it can cause severe anxiety and depression. And these are the cytokines that are disrupted with the post-finasteride syndrome. So the point of just pointing these out is that you can see that there's a great overlap with all of these seemingly disparate entities, and our brain peptides have proper activity against all of these. So all of these entities should be somewhat amenable to our brain peptides. This is a chart of just the peptides, the 3 that we discussed: cerebrolysin, Cmax, and Salank. And the 0 to +3 are the properties for each one of those. So if you have a patient who's having pain and is in her 60s or 70s and having a cognitive function, Cmax would probably be a first choice. Cognitive function with inflammation would be cerebrolysin, and in Salank, we would like for if you need some weight loss and some cognitive issues here. So this is kind of a handy chart that we can use to quickly, pinpoint which of the peptides are most useful here. This is the continuation of that. I couldn't get it all on one slide. And as you can see here, memory, attention, and it's neuroprotective. Here are the doses, and here are the indications here. The next two slides are actually some other peptides that we use. And I'll just mention them briefly. PT141 is actually for sexual dysfunction and libido. There's a little bit of a weight loss here. It is now actually an FDA-approved drug called Vyleesi. So it went from about $50 a month to $899 a month, but with coupons, at least here in the US. CMAX and Selank, we've been discussing. This is CJC 1295 with epimorelin. So this is your growth hormone mimetic. So when we want to when we need a growth hormone improvement, this is our go-to here. And as you can see, we have it for anti-aging, weight loss, cognitive function. It's an antioxidant. It helps with sleep. Here are the doses here. Here's a couple of other peptides. And the two most important ones, thymosa alpha 1, thymosa beta 4. We use these all the time, and we use these for quite a number of different issues. Immune boost, immune function, carcinomas, infections, even for, we have a protocol for hair loss. BPC 157, again, is another peptide, an extremely interesting one. This was actually I isolated and identified by Pavlov in 1904 with his dog experiments. He identified that there was this substance. He didn't quite know what it was, but he was able to separate it out of the gastric juices of dogs, and he was actually selling it to and using it for gastric ulcers and upper GI and duodenal ulcers and upper GI symptoms. Here are the doses here. It comes in the oral form for, we use that for GI issues, and it comes in a sub-Q, and we can do it intra-articularly for wound healing and for joint repair. Epithalon is an anti-infective. It's useful against Lyme disease. It has antiviral and antibacterial and anti-fungal properties. Here are some over-the-counter remedies that we use quite frequently that also have effects against the cytokines that we mentioned. For memory loss, we like pregnenolone, which is a hormone of memory. Green tea extracts, spironolactone and metformin are drugs. Ashwagandha, which I'm sure you're all familiar with, and mucuna pruriens. For slow thoughts, progesterone, pregnenolone, and saw palmetto. And I gave you these, again, these are all, can be all separate topics, but I gave you these as just sort of a handy chart, and it's sort of a go-to if you need something, a reference. Fenofibrate is actually in the US, is a drug for high triglycerides, fats other than cholesterol, but it acts on a pathway that increases allopregnenolone, which increases GABA, which is your anti-anxiety agent. It acts similarly to the peptides that we talked about, Selank, and also your benzodiazepines. Vitamin D3, green tea extract. For comprehension, progesterone, we usually use it in the cream form, and fenofibrate. And for anxieties, spearmint tea and peppermint tea, which will lower testosterone by up to 23% at 100 milligrams a day for 2 months. Resveratrol, progesterone and pregnenolone in fairly high doses, which will increase allopregnenolone, which increases GABA. And there's our benzodiazepine effect. Saw palmetto also lowers testosterone and the quote unquote road rage of testosterone. Ashwagandha and Chinese skullcat. For depression, progesterone and pregnenolone. Piaglizone, which is a anti-diabetic drug in the US called Actos. brexanolone, which is a synthetic allopregnanolone, and that also is very interesting. It's recently approved in an IV form for postpartum depression. It's a little impractical though. The treatment is an inpatient IV infusion of brexanolone for 60 hours straight. And in the US, it's about a $34,000 bill for treatment. But the company's working on a pill form, and keep an eye on this. I think this is going to be your antidepressive depression treatments of the future. GABA, of course, is the neurotransmitter for anxiety. Phenylethylamine, which is also another anti-anxiety neurotransmitter. For suicide, of course, counseling if it's severe, but testosterone, low testosterone issues and growth hormone issues factor into a recurrent suicide ideation. And phenofibrate, GABA, and this is ketamine in a nasal spray. For insomnia, we have progesterone and GABA. There's some combinations. And again, I just wanted you to have a little chart to use as a reference. These are the go-tos that I use. Also, sulforaphane will increase dihydrotestosterone, which will convert into allopregnanolone. I want to thank you for inviting me. I am the executive director of the American Osteopathic Society of Rheumatic Diseases. On Tuesday nights at 5 p.m. Pacific, where I am in the U.S., which is 5:30 a.m. in your time zone. Unfortunately, we have a educational webinar every week on a variety of topics. Usually, it's of integrative medicine. Peptides are certainly one of them. There's of course a lot of interest in treating and the COVID-19 issues, including the vaccines. Here is our web link. It's the same every week. And we will be in Phoenix, Arizona, October 22nd to 25th with our OMED, which is the largest osteopathic scientific convention every year. And we present mini courses on a variety of integrative topics. I do introduction to bioidentical hormones. We also have a cannabis group. We have a group that does practice management, and then we have a group that does a general integrative medicine. If you're ever interested, we can probably, because we will have a web, a Zoom hookup, and we can most certainly have your students tune in on that, and it will also be recorded. So I thank you so much. If anybody has any questions, this was a difficult topic to begin with. I hope we got a little bit of an introduction, and we were able to find something useful for that from this. There's my contact information. And doctor, if we are completed.
Thank you so much, sir.
Thank you.
I would like to have few questions with you. Sir, how would you have started your journey to this field of osteopathy?
It was a long journey. I was always a little bit, so I'm a regular medical doctor. I was an OBGYN for a while, and it was not compatible with my lifestyle. I went into family medicine, and I sort of found my way into integrative and alternative medicine because I wasn't satisfied with the way medicine was accepted here. So early on, I went to UCLA School of Medicine, and they had a acupuncture for physicians course, which I took and sort of jumped in wholeheartedly. And where I lived in Northeast Pennsylvania at the time, there was nobody doing acupuncture at all. So I quickly became, very very accomplished with the techniques that I acquired, and I quickly filled up my practice where I had a 6 month waiting list. I took on some other colleagues, and we had a very nice, a very good, flourishing acupuncture practice. And on the side, I had a general, a medical doctor practice. Unfortunately, I had some family setbacks, and my wife and I separated and divorced, and we were divorced. And then now I was in my mid 40s, and I just wasn't feeling well. I just wasn't feel. I was tired. I was run down. I just didn't have any energy to pretty much do anything. And I still had 2 young children that I had to raise. And I came across a physician in Southern Florida who was teaching testosterone replacement. And so I went and learned how to do testosterone implants. And the doses we use now and the technique that we use now is nowhere near what we did then. But I felt better almost immediately within 2 weeks. And I said, if I'm feeling this way, my patients must be feeling this way also. And so that kind of got me, that's what got me started on the on my my road to the hormone replacement, anti-aging side of my practice. Then about a year after that, I went to a conference again in Florida, and one of the topics was, and this was around about 2003. One of the topics was taking this. You can't even see it in the bottle. You reconstitute it with some normal saline and put injections in the patient's face, and the wrinkles go away. I mean, it turned out to be Botox, but at the time nobody knew what that was. And I brought it back, and not even the plastic surgeons in our town knew what that was. So I was the first person in Wilkes-Barre, Pennsylvania to do Botox. And then from there, well, can we do the fillers? Can we do the facelift? So we learned a whole technique of, a whole system of doing a whole facelift without surgical, intervention. It's not as good as surgery, but it will last up 2 to 3 years, and it's quite acceptable, and it's certainly much less costly. I love doing it. We teach it now. We're teaching it to others, our technique, and it's quite exciting. And patients, you see almost an instant. It's an almost instant gratification, and the patients love it too. So between our anti-aging clinic, which is sort of takes care of the inside, and our facial aesthetic clinic, which takes care of the outside, we are, basically doing holistic medicine. That's pretty much how it got started.
Yes, sir. So my next question would be, sir, how safe and effective the hormone replacement therapy? Because most of the time it says there are some changes will be there. There are some difficulties to have hormone replacement therapies, or there are some side effects too. So how you deal with these things? Because every individual who comes to you, they have certain questions to deal with. So how you deal with those kind of patients?
Okay. Again, I have a whole lecture just on that, and if you're ever interested in that, I'd be happy to give that. I'd be happy to give that to you. In a summary, the problem with the hormones and all of the hullabaloo, all of the hysteria was the hormones that were used and the hormones that were used before this. There was this Women's Health Initiative in 2002 were all synthetics. The natural hormones, the plant-based, natural, chemically the same as we make. Again, you have to know what you're doing. You have to know how to prescribe them. You have to know what to look for, if it's too much or too little. But we do not get the elephant in the room is cancer. We do not see cancers with the plant-based natural hormones. And that's number one. So you never prescribe. I don't even know why they're still on the market here, but they are. But we never prescribe synthetic hormones. Only, like I said, plant-based natural ones. And then those are extremely safe as far as cancer is concerned. The next issue is how do we balance them? And that's, again, it's education. I mean, that takes time. When I learned something along these lines, like I mentioned, I went to UCLA's acupuncture school for physicians. It took me 5 years to become comfortable with doing the acupuncture techniques that we do. And of course, things change over time. The same thing with hormones. It took me 5 years to sort of, before the light went on and the aha, and said, okay, yes, now I get it. So, it takes study. You have to want to do it. There's a lot of, a lot of myths that have developed around hormones that are simply not true. If when you take the time to study the literature, you will see that it will make sense. So in our practice, I mean, our basic history, physical, and exam revolves around hormones, and that's how we do it. And by the time we're done asking questions, our hormone questions, we've covered 95% of the systems of the body. And our students, because we have medical students rotating through our offices all the time. Our students are simply amazed at just a little bit different perspective. It makes things fall into place. They seem to make sense. So, like I said, it's education. It's also, having the confidence to know what to look for and when to look for it. When you're starting out, everything seems a little bit strange, but with a little bit of practice, it's not that difficult.
Definitely, sir, it is not difficult. But my next question would be to you: what are the changes have you seen in the due course of time in the medicine or integrative medicine? Because when you started medicine, it was a different era. Now it is an informative era or communicative era. So what was the difference?
The number one difference is that we're very well accepted anymore. Back in the day when we started our acupuncture clinic, and we actually started a weight loss clinic in the hospital, the powers that be, we were shunned, quite often, and called all sorts of names. I was called, in a derogatory term, a shaman, and it was not in a healing medicine man term. There's actually a definition somewhere I found. It was a dweller of the dark arts. I've been called ridiculous, and at the VA until we started seeing the traumatic brain injury patients, and when their patients came to us on 13 medications with 34 pills a day with terrible side effects, and we were able to fairly quickly, within 4 to 6 months, get them off of all of the medications or nearly all of the medications and restore their hormone function restore their cognitive functions with hormones and with peptides. It took a while, but finally they're starting to pay attention. They're actually sending us patients now. So I'm an osteopath. I'm a doctor of osteopathy. The American Osteopathic Association actually sent spies to our, we knew who they were, sent spies to our conferences looking to shut us down. But we were so complete and so scientific that in our last accreditation cycle, they gave us a 4-year accreditation, and the 5 years is their highest recommendation. So I think it's acceptance. I think a lot of it has to do with patient education. The internet does seem to have some effect on us being accepted, and we do everything we don't do wild, crazy things. Everything that we do is evidence-based. Everything we do has literature backing it. And so when I get a letter from an endocrinologist, say, who sent to me, and I have this in one of my lectures, says there is no, in capital N-O, evidence to use testosterone in women for any reason. I quickly shoot off. I have 247 references from peer-reviewed journals on discussing testosterone in women. And of course, there's thousands of them, but that usually gets the point. They usually get the point.
So my question is related to hormone, but it was not for the topic what we have discussed today. There is a disease called alopecia, hair fall, and it is
Right.
a very big industry in the India or in the world that is coming up to treat with these alopecia for different treatments. So there is a hormonal treatment. They say because of the testosterone hormone, this problem is coming up in the male have a more hair loss. So how do you think that to have an integrative approach to reduce this only the approach towards allopathic medication and have a different approach to treat the patient?
Okay, so well, that's again a whole nother lecture. Real quickly, there's three main causes of hair loss. One is called alopecia areata. That is, I believe that's what you're speaking about, patches of hair. And then there's androgenic alopecia, which is male pattern baldness. And then there's a third
Sir,
one.
yes, sorry to interrupt you, sir. Androgenic alopecia, what I was mentioned in my question.
Okay, so androgenic alopecia is hair loss, usually associated with elevated dihydrotestosterone. And typically the drug, which I mentioned, I showed that on the slide there with the one of my 4 areas with the cytokine abnormalities is finasteride, the trade name Propecia. And unfortunately, so how that works is it is a 5-alpha reductase inhibitor. 5-alpha reductase is an enzyme that converts testosterone to dihydrotestosterone, and that an increase in dihydrotestosterone causes the hair follicles to become coated with a waxy coat, and it actually chokes them off and kills them. And that's where the androgenic alopecia comes from. It was thought to be genetic. I mean, it does happen in families, but it can be reversed. So Propecia or finasteride, for the most part, only stops the hair loss. You only get about a 10% hair regrowth with finasteride, but it stops hair loss. The problem with finasteride is that in about 1% of patients, and that doesn't sound like a lot, but in the US in 2018, there were 11 million prescriptions written for these 5-alpha reductase inhibitors. So you do the math, 1% is about 100,000 patients develop what is known as post-finasteride syndrome. And again, that's a whole nother topic. I actually gave this talk at the Age Management Medical Group in April to about 400 doctors. So 5-alpha reductase, which converts testosterone to dihydrotestosterone, when you block that, you block the hormone dihydrotestosterone from its ability to strangulate or to affect hair. So the hair will, for the most part, stop. It will stop the hair loss. It doesn't really stimulate hair growth all that much, and we need to use some other techniques for that. However, again, in 1% of these patients, we find some severe side effects. And the severe side effects can be sexual dysfunction, erectile dysfunction, and symptoms that are like anxiety, depression, and even suicide ideation. There have been 80 suicides that have been linked to the use of this drug. And the reason is, and again, we're back to with the topic that we talked about, increasing, the drug, the peptides that we talked about, increased allopregnanolone. 5-alpha reductase converts progesterone to dihydroprogesterone to allopregnanolone. via 5-alpha reductase. So when you inhibit 5-alpha reductase with finasteride, you're inhibiting that that pathway also. And what you're doing is you're diminishing your calming neurotransmitter, which is again GABA. We get like these wild transmissions, and we get panic attacks, anxiety, depression, and even suicide ideation. Again, that's a whole, I have a whole lecture on that. I have a 64-page paper on it, if you'd like, also with over 200 references, just on this topic alone. So I'm glad you asked about it. So there are a number of strategies that we use that are effective and that will not have quite the severe mental side effects. So one thing we can do is we can actually make a gel or a cream out of the finasteride, and we can mix that with minoxidil, which it was actually developed as an alpha blocker, for high blood pressure. Minoxidil increases blood flow to the scalp, and so and what happens with the finasteride ointment is it will block the forming, the strangulation of the hair follicles just locally. So we make a combination of usually finasteride with minoxidil, and I like to throw in a little bit of low-dose naltrexone, 1%, and low-dose naltrexone. We make that into an ointment, in a hypoallergenic ointment. We have the patients use it for anywhere from 6 months to a year. And then, but once a week, what we do is we have them use what's a derma roller. I don't know if you're familiar with that. It's a little handle with a little, it's like a dermabrasion, and it has a little handle with a little roller on it. It has little tiny pins. They could be anywhere from 0.25 millimeters up to 1.5 millimeters. And you want to scar the scalp a little bit. So we only do this once a week. They want to draw a little bit of blood. We make so the top of the scalp, we make it an imaginary sort of like tic-tac-toe board with nine quadrants, and you roll we put the cream on, and then we roll the derma roller over the whole scalp so that it seeps in. That seems to be quite effective, and we don't get those, the severe, the terrible side effects that you can get from the medication. We can actually use sulforaphane, which I mentioned earlier, for an increased hair growth. And then also we've used thymosa alpha-1, thymosa beta-4 in alternating dose months, 3 weeks on, 1 week off. And they also increase hair growth, and they decrease dihydrotestosterone. So that's a typical protocol. Hair growth, it takes anywhere from 8 months to a year. It's not an instant gratification. And so we have patients come in every 2 to 3 months. We take pictures because early on they don't see a whole lot of change.
Yes, sir. So it was a great answer, but I think so it can't be answered in a very small way. It is a long session. We needed to understand how androgenic alopecia is coming up, how we are giving the treatment, how patients are getting treated. So is there any way that minoxidil can be taken or withdraw from the patient's life, or it would be continuous for whole lifetime?
Well, the problem is with these medications is once you stop using them, the DHT issues recommence. So you have to use them all the time. So there's herbal remedies that will give you a similar effect. There's lots of hair gels, creams, those kinds of things that work. A 2% ketoconazole, which is an antifungal agent in a shampoo, is also sometimes useful for androgenic alopecia. But there isn't one thing. We don't use one thing. We use all of the tools that we have. It would be nice if there was one thing, but a lot of times with these types of issues, and life just isn't that simple. So I'm sorry if it's a long, winded explanation, but that's my explanation.
Thank you so much. My last question would be to you that there is a treatment for these all the very small treatment they are coming up in India, that is PRP, which is a very common treatment for this alopecia problem or androgenic alopecia. So is
Mhm.
this treatment safe or is this treatment advisable for the patient?
What is it again that you're doing?
PRP, platelet rich plasma.
Oh, platelet-rich plasma. Yes. Okay. So we do that also. Yes, that's actually quite safe. We take the patient's blood, we spin it down, and we get the growth factors out of it, and we'll use that uh, uh, quite successfully, like the hair cream that I mentioned. And in our clinic we'll use it with we have an electronic dermabrasion pen, so an electronic derma roller. We'll do that, and we'll do that once a month for 3 months. This is an add-on. Some of these procedures, at least here, are kind of expensive. Those are quite safe because you're using the patient's own blood and their own serum, and we use that on the hair. We do use that with our facial treatments also. We can do it for. It also will help for breast enlargement and for urinary incontinence and for sexual rehabilitation. Also, we use PRP. So yes, we do that quite extensively. When we first started doing it, it would take us an hour to an hour and a half. Our first itineration. We're on our 4th generation equipment now. We can get the PRP from the patient and ready to be used within 9 minutes now. So it's been quite an advance, and I've been doing this for about 5 years.
And how long the treatment should be going on? Is there any time specification?
How long does the procedure take, or how long do we keep doing this?
Yeah, how long this procedure take to regrow the hair or help the follicles?
To regrow, we tell our patients to regrow hair. It's a year-long process, and depending on what modalities we're using, sometimes they have to keep it. They have to keep doing it. I mean, once you stop it, our bodies are stronger than our external methods. So unless you're going to do a hair transplant or a hair weave, you're going to have maintenance. And the maintenance is really for life if you want to keep it that way. But we'll get about a 30 to 40% increase in hair density. The first itineration usually is that the hair loss slows down about 90%, and then we get a hair regrowth. We can get up to 30 to 40% when we use our combinations.
Thank you so much, sir, that we have taken the questions from hormone replacement to alopecia and much another thing with your journey too. So it was a great session in a whole. I would not talk about just hormone or peptide. It was a great session. And we as a student, we wanted to ask that if we want to learn from you, if we want to connect with you in offline mode in future, so what would be the process? Is there anything workshop that we can come over and learn from you? Is there anything that your university?
I actually have I have about 10 hours of recordings, introduction to hormones. I think I sent you the list. I have 10 hours of introduction to hormones, the steroidogenic pathway, which is the science of how the hormones are interrelated. What you need to know about men's hormones, what you need to know about female hormones, the thyroid. I have a whole lecture on low dose naltrexone, and then there's a lecture on, it's about 2 hours long, on putting it all together, how to go about, what to look for, how to do it. And I also have the handouts that we use, and we can get you those if you're at all interested.
Thank you so much, sir, that we would connect with you. We would love to connect with you because your journey and the way you explain, it covers a lot of things. And as a medical student, I think that would be the approach for us to develop or to grow in the future. So thank you so much, sir, to come on our platform and share your wonderful time and everything with all of us.
Thank you. If I could ask, if you could send me the recording when you have it done, I would be very happy about that.
Sure, definitely, sir. Definitely.
Okay, thank you. I appreciate you reaching out to me and, giving us this opportunity. If there's anything else you'd like I said, I do have recordings of quite a few lectures. The topic you picked was actually quite complicated, and wasn't a basic. So, we'd like to start at the beginning. I think that would that would do you and your fellow students a better service.
Definitely, sir. And thank you so much that we will connect again with you with some another lecture, with some another insight to learn, because learning will never stop with anyone. So we will definitely connect.
I agree.
Thank,
Thank you so much.
thank you, sir.